Hello friends, today we are going to discuss about the prone position. As we have seen the many cases of the ARDs in our ICU, we have seen whenever the patient is going into the refractory hypoxia, that means if the PF ratio is less than 150, we are giving the prone position to the patient. So we'll see in this lecture what exactly is happening when the patient is in prone position. So human lungs, as we all know, the human lung plays a critical role in cellular respiration by efficiently transferring atmospheric oxygen to human circulation. And the prone position exposes the human respiratory system to the different and complex physical and physiological interaction. These include the impact of gravitational forces, the interaction of surrounding structures like heart, diaphragm, body weight, and habitus, physiological changes in the lung vasculature and the pleura. So whenever in supine position, what is happening? The hydrostatic pressure generated by the weight of the lung, heart, abdominal pressure leads to the more negative pleural pressure ventral. Consequently, when the pressure human lies in supine position, the alveoli are which are present anterior portion of the lung, they are distinct. In comparison, the alveoli which are present into the dorsal region of the lung are less distinct. So when in supine position, the patient changes to the prone position. The gravity and the compression of the surrounding structure redistributes various dynamic pressure into the respiratory system. And the posterior pleural pressure becomes more negative compared to the anterior pleural pressure. The heart displaces towards the sternum and the surrounding diaphragm shifts the cowling. And the prone position ultimately leads to the more homogeneous distribution of ventilation by inflation of underinflated or the collapsed posterior airway and reduction into the anterior alveolar hyperventilation. Although the improved positional ventilation homogeneity is crucial in capturing atmospheric and supplemental oxygen, its impact on oxygenation can be achieved only if equivalent matching of pleural perfusion exists. Ideally, the adequately ventilated alveoli should have matching and adequate blood flow, thus using their full potential to transfer the oxygen to the circulation. And the ideal ventilation perfusion ratio is 1, implying that the ventilated oxygen is exposed to the perfusing vessel. So if there is any disparity in this ventilation perfusion ratio, then that leads to the mismatching of this VQ ventilation and perfusion, which leads to the hiring or lowering of the VQ ratio from higher and lower than the 1. Now the next thing which is changing in prone position is the perfusion. Now what happens in the supine position? The gravitational forces leads to the higher perfusion into the posterior. But there is a since so even if the perfusion in the posterior alveoli is high, the alveoli which are present into the posterior region are compressed. So there is a no so because these alveoli are compressed and they are poorly ventilated, they are not taking any contribution in maintaining the oxygenation. So even if the posterior alveoli are receiving highest perfusion, they are poorly ventilated, and the patient that creates the greater degree of the VQ mismatch, leads to the poor oxygenation. So whenever we are shifting this patient to the prone position, there is a reversal of the gravitational forces. Shifting of the surrounding structures such as the heart, diaphragm, ultimately leads to the more homogeneous lung perfusion. And then this prone position will improve the VQ mismatch. A recent study using the high resolution functional lung MRI showed that VQ ratio approaches 1 to 1.6 in the prone position, which is more risky. Now, numerous physiological studies of ventilation perfusion have been performed since 1960s using variety of methods, including radio spirometry, single photon emission CT scan imaging, PET scan imaging, and MRI. Although some studies demonstrate no changes in the positional shift in the ventilation and perfusion, most studies, including the more recent one, that use high resolution functional MRI suggest improvement in the VQ gradient while the patient is in the prone position. So under normal healthy circumstances, differences in the body position have little impact on the overall oxygenation because of the robust compensatory mechanism such as high reserve for ventilation and perfusion. However, positional changes can impact the disease and compromise respiratory system substantially. Prone position may lead to better oxygenation in one group of the patient, where other group may not realize the differences because of the numerous complex factors that must interact to improve oxygenation. And these factors include degree and location of pathophysiological process such as atelectasis, consolidation, pulmonary interstitial syndrome, local and regional differences in the perfusion, and the impact of hypoxic vasoconstriction, cardiac output, and anemia. Additionally, specific interaction can supplement the impact of the prone position, like addition of the positive end expiratory pressure by mechanical ventilation or high flow nasal cannula, reducing the patient ventilation dysynchrony by sedation of the neuromuscular blocking agent, and using medication that help to improve pulmonary vascular bed flow and cardiac output. So this is the diagram which showed the impact of the ventilation and perfusion when the patient is in supine position and when we are pronated. So we'll see the impact on the ventilation. So when the patient is in supine position, the alveoli which are present on the posterior region are compressed. So this compressed alveoli is not receiving any ventilation. While the alveoli which are present in the anterior position, they are more distended, but they are poorly perfused because of the gravitational effect. So when we are shifting this patient from the supine to the prone position, the anterior alveoli are the anterior alveoli are now opened up, and then because of the gravity, they are also receiving the more perfusion. So the effect of this is the improvement in the VQ mismatch, and the more homogeneous, because of the more homogeneous distribution, there is the improvement in the oxygenation. Now we'll see what is the effect of the hemodynamic on the prone position. Prone position affects the venous return detriment and may increase the right ventricular preload. So venous return is the blood flow from the systemic venous network towards the right. Now, according to the Guyton's model, venous return is equal to the venous return pressure gradient divided by the resistance to the veins. So the pressure gradient of the venous return is defined as difference between the mean systemic pressure and the right atrial pressure. Now, because of the prone position, there is increase in the intra-abdominal pressure also, which may cause the two distinct effects on the venous return. So one effect, so prone position is increasing this mean systemic pressure and central venous pressure to lesser extent, resulting into the increase in the pressure gradient in the venous. This effect are due to lowering the trunk from semi-recumbent position to the strict supine horizontal position, and secondary to the passive shift of the blood from the splanchnic compartment to the heart as occur during the passive latency. And the transferring the patient from the strict supine to the prone position, the effect that is predominant. On the other hand, whenever the patient is in the prone position, there is increase in the intra-abdominal pressure induced by prone positioning, which increases the resistance to the venous return. So, an increase in the venous return can be observed only when there is an increase in the pressure gradient, which is not countered by the increase in this resistance. So the increase in the venous return results into the increase in the right ventricular preload as assessed by increase in the CV. So this prone position may decrease the pulmonary vascular resistance in the right ventricular shaft. So whenever the patient is in ARDS, right dysfunction is not rare and its prevalence is ranging from 10 to 30% in large observational study. So severe RV dysfunction was shown to be associated with the increased mortality. And what is the main cause of RV dysfunction? So main cause of RV dysfunction is the increase in the right ventricle after load secondary to the increase in the pulmonary vascular resistance. The later, so why there is increase in the pulmonary vascular resistance? So this resistance is increased due to hypoxic pulmonary vasoconstriction, to the inflammatory mediator, microthrombi formation, or to the hemodynamic effects of the mechanical ventilation. So the tidal volume at each inflation and the application of the PEEP over entire ventilatory cycle increases the lung. This may increase the PVR by compressing the intraalveolar vessel and thus increasing the proportion of the lung waste zone 2, where alveolar pressure is higher than the pulmonary venous pressure. So prone positioning may reverse some of the mechanism responsible for RV dysfunction during ARDS. First, by improving arterial oxygenation, prone position should decrease the hypoxic vasoconstriction. Second, prone positioning allows the recruitment of the vertebral part of the lung, resulting in more homogeneous alveolar aeration. This recruitment of non-aerated alveoli increases the diameter of extraalveolar vessel in this region. So the prone position also dampens the over-distension present into the hyperinflated lung area. In this way, it should decrease the compression of intraalveolar vessel in this zone and decreases the transpulmonary driving pressure according to the principles described by the White and et al. Moreover, by Moreover, by recruiting the lung unit, prone position can prevent the application of too high PEEP levels. Finally, the prone position can increase the venous return and central blood flow, which in turn increases the pulmonary venous pressure, release the compression of some previously compressed pulmonary microvessels, shifts this vessel from waste zone 2 to waste zone 3 condition. The combination of all these effects should result in decreasing PVR and RV after. It remains to be determined whether the effect of the prone position on the hemodynamics in general and RV function in particular contribute to its beneficial effect on outcome. In this regard, we have already learned that prone positioning could be beneficial in responders as well as non-responders defined by changes in the blood gas variables. So prone position may increase the left ventricular preload. Left ventricular preload can increase secondary to the improvement into the right ventricular preload and afterload with prone position, as illustrated by increase into the pulmonary artery occlusion pressure. Moreover, in patient with the RV enlargement prior to the prone position, reduction in the RV afterload dampens the RV and the LV interdependence, as illustrated by the decrease in RV end diastolic area by LV end diastolic area ratio measured by echocardiography. This should also increase the LV end diastolic volume and LV preload. Now, overall effect of the prone positioning on the cardiac output. Several studies have evaluated the effect of the prone position on the cardiac output with variable result. And some have shown that the prone position have the little or no effect, whereas others have described increase in cardiac output. The changes in the cardiac output with the prone positioning likely depend on the volume status and degree of the preload responsiveness. Indeed, cardiac output increases only in patients with the LV preload response. However, cardiac output may decrease in both preload responsiveness and unresponsive patient if intra-abdominal pressure increases to the large extent with prone position, irrespective of intra-abdominal pressure value in supine position. It is noteworthy that prone positioning can increase the venous return and thus cardiac output only if intra-abdominal pressure is lower than intramural pressure of the inferior vena cava. When profound hypovolemia is present or when intra-abdominal pressure under prone positioning is high, venous return should be reduced. Thus, the major goal when using the prone position in patient with ARD should be to minimize the increase in intra-abdominal pressure, because large increase in intra-abdominal pressure independent of its baseline value may exert some detrimental effect on the circulation. In this regard, in crossover study, Michael et al. Found that using air cushion mattress was associated with the limited increase in intra-abdominal pressure compared to the conventional foam mattress. Also, the use of thoracopelvic support allows the free abdominal movement and may decrease the intra-abdominal pressure. Now we'll see what are the contraindications of the prone position. Absolute contraindication of the prone positioning are the limited spinal instability, while the other relative contraindication have been proposed, which are unstable pelvic and long bone fracture, rheumatoid arthritis affecting atlanto-occipital joint, open abdominal wound, severe burn, late-term pregnancy, increased intracranial pressure, and severe hemodynamic instability. Now, regarding the prone position, the PROSERVA trial was published in NEJM in 2013, which showed in patients with the severe ARDS, early application of the prone position significantly decreases the 28-day mortality and 90-day mortality respectively. So if I want to summarize the mechanism of the prone position, it will be like, when the patient is on the prone position, there is a homogeneous distribution of oxygenation, and it has by changing the position from the supine to the prone, there is a gravitational, there is also change in the gravitational effect on the ventilation as well as on the perfusion, which will which will help in improving the oxygenation. So this change in the oxygenation will happen because of the more participation of the alveoli from the dorsal side, and increase in the perfusion because of the gravitational effect. And the hemodynamic effect of the prone position is entirely depending on the resistance which is created by the intra-abdominal pressure. If this resistance is low, then this prone position will cause the increase in the RV preload, RV output, RV afterload, as well as LV preload and cardiac output, which will prevent the positive effect on the hemodynamics. Thank you, guys.